It's not hard to know that some things just aren't going to work. They're futile, we say. I know that, at least from my point of view, I had a lot of futile experiences. Soccer wasn't going to happen. Basketball was out of the question. And there are plenty of dates I never had. And my friends were more than happy to let me know that it was futile from the start. In healthcare, futility has a far more serious connotation. It's a word that gets used because we need a way to describe a variety of kinds of circumstances. And maybe the most important question in an economy where healthcare is an ever-increasing part of our expenditures, huge, as everyone knows, rate of healthcare inflation, not just in the United States, but around the developed world. We're spending so much money on expensive procedures, on new drugs, and if you break it all out on research, et cetera, well, there's not enough money, depending on who you listen to, for any of a variety of reasons, to pay for all the care that works. So when there are medical interventions that don't work very well, the language of futility, the word futile, is a very powerful word because it can be used or misused to convey an answer to the question, on the one hand, is this something we ought to do? We teach people in medical school what works and what doesn't work. And if it doesn't work, it's futile to do it, right? So there's a kind of a sense generally that once we've decided how to define a disease and once we've decided how to define a cure, then if a thing that, you know, if a witch's brew won't cure the thing that's wrong with you, then it's futile. Don't take it. But it serves another purpose, and maybe it's insidious, maybe it's not, but it's the key word, futility of rationing. The word futile helps us talk about whether or not, given the array of resources available, it makes sense to provide a particular service. We go to doctors because we want medical care. That's self-evident, right? And it's common sense. Maybe the oldest identifiable duty of the physician in Western medicine is to provide therapy. That's a word that has an unusual combination of linguistic roots. Its etymology isn't just Greek, and therapy means lots of things for the historian, but let's just stick to the common sense version. As a common sense duty, the duty to provide therapy is a duty to give people relief from their primary or from whatever disease it is that they're suffering from, or whatever symptoms it is that need to be alleviated. I take an aspirin because I have a headache. Is an aspirin effective for a headache? Well, it is for me, and so it's reasonable to describe an aspirin as therapeutic. You know, it sounds sort of simple-minded to describe it that way, but there are lots of permutations. Terry Schiavo was in persistent vegetative state. When patients who are in a long-term coma, and permanently, they can be their eyes open for 33, longest recorded time, 33 years, 111 days. There's nothing you can do for them that's therapeutic, in the sense that their primary diagnosis is one that does not respond to anything. On the other hand, they have problems like bed sores and recurrent infections that you can treat. So is it therapeutic to provide penicillin or some other form of response to infection to someone who's in a persistent vegetative state? Well, at one level, yeah, it really is, because the infection stops, right? So things are therapeutic, and we say we're providing therapy. And it's a word that people pretty much can wrap their minds around. It's what they think happens in the hospital. They make you better, right? That's therapy. But lots of other things happen in hospitals, and because the idea of not being able to help you is the most troublesome feature of the clinical encounter, understanding the language that we use, and in particular the language of futility, when we're trying to describe what goes wrong, what it is that's wrong when we can't give you, whoever we are, we the insurance company, we the doctor, we your mom, can't give you what you want, or what you hope would provide a cure. Understanding that turns out to be one of the keys to thinking about clinical ethics. I think there's an answer, but I think that talking about some of the features of what you're reading from those who've thought about futility carefully can kind of help understand in understanding what clinical ethicists do and face. So what happens in a hospital that isn't an attempt at therapy? If you think about it, there's a lot. One piece is palliation or palliative care. When you know you're going to die, when doctors have decided that there are not remedies available for the specific malady that you suffer from, apart from pain, the treatment of that pain, the attempt to prevent suffering, that's a kind of activity that requires intensive medical intervention at times, whether we're talking about morphine or any of a wide variety of agents that can prevent a certain sort of suffering, but that don't stop the problem. We call that palliative care. And in fact, palliative care has become so important to an American healthcare system that's otherwise focused on interventions, on helicopters that pick up patients from highways, that palliative care has gone from being an area where physicians have said in the U.S., and correctly, that we're very, very weak, to a principal focus. The failure of the American healthcare system to provide more palliative care is generally considered to be one of the great fissures in our system. So we do things that aren't therapeutic sometimes because we want to alleviate suffering. Sometimes that's because there isn't anything you can do that's therapeutic, and other times it's because people say, no, I don't want chemotherapy. No, you know what, I don't want to live this way for whatever reason, whether they're seeing Jack Kevorkian or whether they're making a decision that's considered and involves their own values. I don't want blood. I'm a Jehovah's Witness is the sort of thing that comes to mind. Another form of intervention that goes on in a hospital that doesn't necessarily provide therapy is the sort of thing that does happen in the emergency room after you fly in on the helicopter, and that's evaluative care. Now, there are other words you could use to describe it. I like that word because what happens in an emergency room, as anybody who ever saw the TV show ER knows, is that very aggressive measures that wouldn't be undertaken anywhere else are the principal focus. So you give someone a respirator, you put them on a respirator, help them breathe. Even if, short of their not having of being dead, you might provide them with care that you suspect will not be therapeutic at all, because the goal, both in the ambulance on the way there, in the helicopter, and in the emergency room, is to stabilize and evaluate. So we provide measures for people because we know aren't going to be therapeutic, because we need to keep you around to figure out what's wrong tomorrow. And that's unfortunately in large part because of the economics of American healthcare, where you can't get a doctor of a certain stripe to be on call in American hospitals across the country. You have to stabilize and evaluate, and often that creates real problems that we'll talk about now, because it's hard to turn off a machine no matter why you turned it on. And then there's just straight up futility. Now, what is futility? It has a lot of different meanings, and in talking about them, it's useful to see that it's a word that's invoked by people who have good intentions, and as well as by those who don't. But those who have good intentions use that word in many, many different ways, but almost all of them have to do with the idea that not only is the thing that you're providing unlikely to cure a patient, but it also can be described empirically as being unlikely to cure a patient. So certain kinds of therapies just aren't provided. A hospital will decide that they don't do something. Laetrile, the sort of infamous alternative medical therapy for cancer, is something that some insurance companies paid for or pay for, along with other alternative medical therapies. But in general, oncologists believe that it's futile to provide that care, and so it's very hard to find a major medical center that would provide Laetrile or peach pit therapy. A recent, a very prominent case involved the pit of a fruit that was provided in Mexico to a young man who refused other forms of therapy for his cancer. It's a decision that's made by clinicians on the basis of their reading of the medical literature that some things don't work. Now, that's a global decision. A hospital can make policies about what they won't provide, period, and they do. And that often Well, it often results in a great controversy. So, people talk about the dumping of patients. One of the decisions that happens in major metropolitan areas is that an institution will say, we just don't have enough money, frankly, to provide X or Y service in our emergency room, so we don't take patients who have that condition. So having declared that that you're not able to do something becomes equivalent to talking about its futility. That's not the most common use. The most common use of the word futile is the one that involves a patient examination. So look at someone and you say, this respirator that's connected to this person, yes, it's helping them breathe. Yes, they are. We can look at the numbers on the little box here, and we can see the degree to which they are oxygenated. Right? We can adjust the respirator settings, but they aren't getting any better. In fact, they're getting worse, and maybe they're even getting worse because of the respirator. But that's not the point. The point is that the respirator isn't therapeutic, and therefore, it's futile. Now, the language of futility is a trap in some ways. In one sense, as Jecker and Johnson and Schneiderman argue, it's a reasonable thing to say that if you look at a therapy, it might produce effect without producing benefit, and you could measure that and say, as they propose, in the last 100 cases, X has not produced benefit. Maybe effect, but not benefit. And if something hasn't helped once in the last 100 cases, they propose that that measure is futile. It's an empirical attempt. Many hospitals all across the United States turn to ethicists and ethics committees, and really only to ethicists and ethics committees, maybe the lawyers, to identify ways to work with futility in the form of a policy. So they'll adopt something like this standard that enables the hospital to say, if in the opinion of the medical professionals who work in the institution a particular therapy is futile in one case or across the board, then the clinicians are not obligated to provide it. Deceptively simple. I mean, of course, it's obvious that even implementing such a standard wouldn't be easy, but it's at least clear, right, what it means. If it didn't work the last 100 times, it doesn't work. The problem is that what it means to work isn't as obvious as it appears at first blush, right? I mean, so when Terry Schiavo's parents say, we believe that there will be a miracle, that God will intervene, then the question becomes, is it futile to continue to sustain a patient on persistent vegetative state if those people who hold a religious view in the United States, where religious freedom is regarded as a kind of guarantee in a number of ways that state-funded institutions won't harm you because of the view that you hold. If someone can point to their religious view and say, you will not turn off the machine because and moreover, I believe God's going to provide a miracle, then the language of futility isn't quite so useful, because you can't do an epidemiological analysis, sort of look across populations with instrumentation and tests, statistical tests, and prove what God does. Right? By the same token, when people say that they'd like an experimental intervention, most cancer patients, at least at some point, entertain the idea of having enrolling themselves in a research trial. If they can, they typically do talk to someone about clinical research. Well, the very nature of research has built into it that you do not know what the outcome is likely to be. And even at the very end stages of research on drugs that are being recertified for a new purpose, you still are in a very different kind of place in terms of certainty. So, is it futile to provide someone with enrollment in what we call a phase 1 trial, a trial of a medication that's designed solely to determine its toxicity of the substance that's on trial? I'm not sure. I can say this much: it's not therapy, right? Because what we're talking about is research and not the ordinary clinical activity of doctors. So look, this is very complicated. And now add to that complication money, right? Futility, many health economists and ethicists argue, became such a big deal because we don't have enough money. So is it futile to provide someone with a respirator for a long period of time? Maybe, but how long? Exactly how long do you wait before you say continuing this care for this person is futile? Now, listen, if there is a clinical ethics case that recurs, if there's a single case that every person who works in clinical ethics will face if they work in a good-sized hospital, even a small hospital, but work in a bunch of different units, it's the case that where the patient's care is being described as futile, whether it's by doctors or nurses, or whether there's disagreement among family members, doctors, nurses, and others. But the word futile gets used, and the discussion revolves around who's right and who's wrong about when you turn something off, and then that word futile becomes the battering ram of those who say enough is enough. There are problems with that fact that the ethicist has to deal with that are very, very hard to conquer. The most obvious problem is that to deny someone the idea that deny someone a therapy on the grounds that it's futile is to make a guess about whether or not it'll work. The doctors make that guess. As an ethicist participating in that conversation, you kind of have to take a position on what the proper empirical measure is, at which point you kill someone. Right? I mean, because for the purposes of a family in an intensive care situation, the subtle distinctions between withholding a therapy and withdrawing a therapy, between active and passive euthanasia, those things aren't what matters. What matters right now is what's sometimes called deathbed rationing. Right? There's a bed here, and we don't have so many. There's a patient here, and it's taking a lot of resource from the hospital, the nurses, the doctors, etc. And nobody wants to be the person who says these resources are being squandered on this patient, but there's a fact that day to day people who are not trying to make money, right, in addition to those who are, people who are not trying to make money, look around them and say, my God, this person's been here 124 days. They aren't being discharged. Why? Because the sun says don't discontinue treatment, but it's futile. There's the conversation. Now, as a clinical ethicist, it's tempting to point to the idea that the numerical standard is a way out. So just tell the son of this mom that what's being proposed is futile, that what's being proposed is inappropriate. And the conversations that ethicists can have with the son are indeed some of the most important encounters in all of medicine. They are revolutionary. They define the involvement of ethicists in medicine. But they also are difficult, and they don't work very often. And what we know, and we don't know a whole lot about ethicist involvement in end-of-life cases and how much it has an effect. What we know is that to the degree it's been measured, it doesn't have a whole lot of effect. The support study looked at what happened when nurses were involved in talking to patients in 5 major medical centers and asking about preferences, talking to family members, et cetera, et cetera. And, you know, it's difficult to describe what they found exactly, but they certainly didn't find that talking with people about what they wanted had a whole lot of effect on what ultimately happened. Now, that figures into this because if you're talking about presenting the case to someone that the therapy they're receiving isn't a therapy, you need to believe that those people will listen and understand, but more importantly, you need to believe that there is an environment, a clinical environment that's out there where people's views of therapy are taken very, very seriously and then subjected to the kind of scrutiny that we subject everything else to in medicine. So, I mean, that doesn't happen. So now here it is, the central issue faced in most clinical ethics cases, and it pivots around a word that appears to be simple, where hospitals want policies. Personally, think futility policies are a terrible idea, but if you're going to work in clinical ethics, you'll probably be working on a futility policy at some point. And what you're being asked to do, in essence, is to try to craft something that that can't be used or won't primarily be used as a way for physicians to get back the power they lost when autonomy became the primary value in medicine. It needs to be, I think in the view of most people, it needs to be a way in which people can be brought into a conversation about what isn't working, right? So a futility policy is almost always written as a kind of a doctrine of force. So it's written to say, hey, look, just so you know, you're coming here, we don't do things that are futile, right? It's written as a kind of a declaration. We do that because in every other respect, end-of-life care involves that other model of patient autonomy. Do not resuscitate orders typically require the signature of and the sign-off conceptually of family members or patients where possible. It's always struck me as sort of odd, right? Because a do not resuscitate order is an order that precisely says that resuscitation isn't going to work, therefore we shouldn't do it. I mean, there are other reasons you could ask for a do not resuscitate order, and those would obviously require the consent of a patient. But people don't start talking to patients about do not resuscitate orders until they think resuscitation, which almost never works, is a bad idea for a particular person, to crush their ribs and so on, the kind of thing that happens in a code when a code happens in a hospital. Why do we ask people's permission? Right? Well, why do we want to know whether or not they'd like to have a do not resuscitate order? By the same token, advanced directives and living wills. People who come into the hospital with them, well, they've already protected themselves in a certain sense against this conversation about futility because they've said what they want. And most of the people who have them, which is a minuscule percentage of the population, have said they don't want futile care, and they've used that word. Those who don't have it are the source of the dilemma. And that's, of course, the majority of people in American healthcare and around the world. If you don't have an advanced directive and you live in a society in which advanced directives have been taught, we teach our medical students that people ought to have them. Most young medical students don't then get advanced directives. Most ethicists don't have advanced directives. But we tell them that that's, well, as Senator Danforth put it when the law introduced in the Congress in 1989 was passed to bring advanced directives like living wills into the American hospital discourse in a big way. What he said essentially is what he said point blank is this is a Miranda warning, right? You don't have one, well, you could have, and if you're stuck, we told you so. And put even in a sensitive way, that creates and has created in the United States a bias to life, some on one political side of the spectrum might say. So what we do with futility, I think, is hangs on how we think about healthcare, how you believe medicine works, what you think medicine does. That's what brings you into a clinical ethics case. And so when someone calls you for an end-of-life case, there's a 99% chance the word futility will be used. How you think about futility is going to revolve around how you think about disease and therapy. So if you believe that what medicine is the treatment of well-understood deviation from a norm that can be quantified. I mean, there's a kind of Platonic understanding of the healthy person, and if you deviate, you're sick, then futility can be defined pretty easily. And in fact, the biggest worry is that you'll have an inaccurate definition using good empirical measurement, or an inaccurate definition of the latitude of patients with regard to their religious views, if you have a religious definition. But if, on the other hand, you believe that the way health care should be delivered involves conversation, and that conversation ought to take place over a long period of time, then you ought to be scared to death about two things about futility. One is that it's deathbed rationing. I mean, that it happens at almost always at the deathbed, and that the decisions almost always involve money and resources. And making a decision that's in part about conserving resources in American health care that revolves around an individual, when we have a third of the American population is uninsured, right? Well, that just smacks, frankly, of focusing in an inappropriate way, or at least a dangerous way, on individuals. It puts the onus on families in a way that perhaps we shouldn't. It becomes incoherent, because how do you apply the standard in an even-handed and just way? And the second thing is that describing futility, by whatever empirical measure you use, is going to put you in a box. It wasn't too long after Terry Schiavo died that two very interesting studies came out. And I wrote about both of them. One was a study that involved administering Ambien to patients who were in persistent vegetative state, and according to the physicians who did it, they got people in persistent vegetative state to wake up. Over a period of 3 years, they administered Ambien, they say, in 3 different publications, 3 different journals, including one major journal. And one patient, threw a baseball for a while. Another patient told stories about life and how miserable it was to be in PVS. And then they, after about 4 hours, they dropped back into PVS. And by all measures, that's where they were, right? So there were a number of ways you could respond to that. But what if it's true, right? Another study that was released at roughly the same time was a study that analyzed the level of brain activity in patients who have persistent vegetative state. And specifically, they looked at the responses using neural imaging of those in PBS to particular kinds of conversations and stimuli, and they looked very similar to the responses that one might normally see. So the question, of course, that one asks in both situations is, what if these patients whom families say, please keep them alive, don't kill Terry, right? And they go to great extremes in that fight. What if, right? Futility is an awfully strong claim, and it's used as I said, in a number of cases as a baseball bat. And even when it's compassionate, that use of futility as a declaration of force and the authority of the healthcare system, well, it may make sense, but as an ethical strategy, if you imagine the rest of your life, the cases where you use the word futility, you don't usually use it that way, right? So it may be futile to buy a lottery ticket. It may be futile to ask for that date that I was talking about, and perhaps it was futile at the end of the day. Definitely futile to think I'd play baseball, soccer, or basketball, or any other sport. But frankly, those who told me so, they weren't telling me so because they were trying to, at least I don't think they were trying to kill me. I mean, kick me out of an environment where I consumed resources. And it was a different use of the word. And I think that's it, right? Ultimately, at the end of the day, as a philosopher, as an ethicist, as a historian, as a doctor who thinks about ethics, futility is where it's at for identifying your skill set and your disposition. And so if you can really reflect on the cases that we're going to look at about futility in a careful way, look at the ones that have been studied over the years, the ones that have kind of defined bioethics, and look inside yourself to think about what kind of moral reasoning you use. Where's your disposition? I mean, there are people who just go crazy, nuts with anger about cases that seem to be profoundly futile, and how can we waste money, etc. And then others who say, there's nuance here, I'm not sure where I'd go. I'm not saying look to see what your opinion is. I'm saying think about how you think. Because in clinical ethics, a lot of understanding futility is a great demonstration of the sort of ethicist you'd be, and whether ethics is a specialty or not, knowing how much subtlety, how much ambiguity you're willing to tolerate. Well, ironically, that's at the heart not only of what kind of ethicist you are, but at the very meaning of futility itself, which is to say at the meaning of what it is we do in a hospital and what is healthcare. So it's a great example of how ethics is at bottom the study of what it means to give medicine to cure illnesses either of the soul or of the body.